Hi, I'm Jake Runyon, Senior Manager for Center for Perioperative Leadership. And I'd like to thank Jamie Weber, Director of Perioperative Services, for joining us on Periop Talk. We're not only called to care for every patient, but we are also expected to provide each patient with an optimal experience from the beginning to the end of the care episode. Jamie runs a robust gender-affirming surgical program, and she's here to talk with us about how to provide inclusive care to transgender and gender-diverse patients in the perioperative setting and across the continuum of care.
Welcome to Periop Talk, making surgery safer one podcast at a time, with brief, practical information for you to take back to the OR.
So excited to have you with us today, Jamie. How does your unit ensure a patient's name is used consistently throughout the perioperative journey?
Well, that can get a little tricky sometimes as patients will come in and their names may not match their documents or what's printed on their armband. So we have a few things in place that we do to ensure that we get their name correct. First and foremost, we get a lot of the information from our physician's office, and they're really good about making sure that we have that information if there is any disconnect. When we do our pre-admission interview, our nurses are really good about that too, about ensuring that we ask in our EMR, we have a space to document our preferred name and our pronouns. So for instance, if you come in and your name's Robert and you want to go by Bob, it's no different for any patient to come in and have a preferred name over a given name. Some people use their middle name, things like that. So first and foremost, that's how we approach everything. On top of that, if we do have other instances where maybe things don't match, we will have double documentation on our unit where we're very clear in writing that, like on our surgery schedule, that we've got the patient's chosen name written down somewhere where everybody in the team can see it. Additionally, we offer every patient that walks through our doors the opportunity to use an aquaband. These aquabands are great because they're used for any patient, not just our patients that are receiving gender-affirming care. But we write their name and pronoun on that band. So if you see that, it's a little bit of an indicator. We want to make sure that that's inclusive, though, and we're not singling anybody out, and it is optional. So while patients are not required to have it, if somebody, wants to make sure that their name and pronoun is used in a way, that's one way we do it. We also have a few other means throughout the organization. In our patient rooms even, we will have a welcome board, just any standard care board, but we put their name and their pronouns both on that board as well.
Are there resources available to staff to be able to educate themselves about transgender and gender diverse identities?
Absolutely. So our hospital has actually received awards for our staff members going above and beyond in DEI education, diversity, equity, inclusion. And one of the things that we do pride ourselves is our gender affirming care. So we have a lot of resources in the hospital. We make sure that people get education when they start the organization. We're talking everybody, not just nursing. They receive education when they join our hospital. They receive education annually. So that's just the first place to start. We also offer symposiums throughout the year. We have all sorts of other education. We do things like Trans Day of Visibility. We'll do some talks throughout the hospital where we have speakers or patients that want to give a testimony, and we'll do a lot of events surrounding that. We're always looking at community events and inviting people to come and speak, and we provide those opportunities for our staff as well, and we promote those. In addition to that, we also have organizations such as WPATH, where we'll find out that they might be having, some sort of lecture or some other education, and we'll share that throughout the organization.
So communication, resources, those are all great. Us nurses like to follow the rules. So how does your unit handle situations where a patient's legal documents don't match their chosen name or gender marker, Jamie?
So in that instance, we start with heart I mean, we know that we are bound by certain constraints, like, their insurance needs to match their legal name and that needs to match the EMR. But how we address that patient and how we show up for them doesn't matter. So while we do preface that with them when we come in, that, we may have to, use this name, or usually the gender marker isn't an issue, but it's usually the name. We may have to say this name, to verify who you are. We will do our best to make sure that it is minimized, for your safety, but we want to make sure. So we usually just do a lot of education about why we have to do it and minimize it and move on. Even when we are in the OR, if we do have something where, we're putting the patient's name up on the board, that's not a legal document. We will just use their chosen name in that situation. Again, it's no different as if somebody comes in and, their name is John Michael and they go by Mike. They are using their chosen name. We might have to do it for the timeout portion, but again, we'll preface the patient, because every time we use a name that they don't identify with, it causes harm. And we really want to minimize that experience.
Jamie, I realize your program reaches across the organization. So with that in mind, what other strategies would you highlight that help create a welcoming and inclusive environment for transgender and gender diverse patients in the perioperative setting?
So again, that's all about starting from the second they walk in the door, working in partnership with our physicians to make sure that we have all of that information from the get-go. We really do want it to be a welcoming experience. For our physicians, they are used to having to go into an organization where they have to teach nursing. Whereas I'll get new physicians that are, coming to do surgery here, and they are like blown away that they don't have to teach this information. This is something that they're using in their offices already. So being able to continue that experience from their interaction in the surgeon's office all the way through the care continuum, that starts with everybody, our EVS personnel, our security personnel, registration, and really making sure that everybody has a handle on the fact that this isn't just a nice thing to do because we have a gender affirming program. We're doing it because it's the right thing, because it's a basic human right to be identified in a way that you want to be identified and be treated with that dignity and respect.
So going even more specific, I'd like to transition in your pre-operative environment, right? So thinking again, that day of surgery, they're coming through the pre-operative area. Does your unit approach the pre-operative assessment for transgender and gender diverse patients, considering potential interactions with hormone therapy or past surgeries? Is there any consideration there?
There is, yes and no. And it's funny because everybody thinks that gender affirming care means surgery, that we're doing mostly bottom surgery. That's what folks identify it with. And that is absolutely not the truth. So I think in that respect, it is about education, and we do have ongoing education. We provide other education outside of our hospital to other professionals for that reason. But really, when we look at it, it's no different than anybody else. And there really isn't anything specific to gender affirming care that's going to make or break that patient's interaction in the perioperative setting, at least from a nursing perspective. So you bring up hormone usage. It's no different than if you have, a woman who has had a hysterectomy and is now on hormone replacement, or a woman who's had breast cancer who's now on hormone blockers, or a man who, for whatever reason, needed to take estrogen due to a cancer diagnosis. You're going to get folks that don't fit into that category where there's some interaction. Outside of that, there isn't a whole lot in the perioperative setting that we're going to be concerned with. There might be some things later down the line when you look at the spectrum of care for the whole person that, maybe their lab ranges might be different than you're expecting if they were trans versus cisgendered. So, if you have a trans woman, her lab values for her H&H might be a little different than a cisgendered woman. So, maybe knowing that, but nothing that's really going to make or break your care there as far as hormone replacement. Now, organ inventory is a totally different beast. And I think what our approach is to really make it more inclusive of everybody, particularly not saying, what surgeries have you had? That's important to me. Do you still have a penis? Or, these very just gendered and out of context lines of question. That doesn't matter to me as a nurse. If I'm doing appendectomy on somebody, I don't care if they've had bottom surgery or not. It makes no difference to my care that I deliver. What is going to be important is looking at organ inventory. And this is particularly important when you start looking at people that are of childbearing age. So hormone replacement in that grand scheme of things may not be important as to do you take hormones or not? And, could you get pregnant? That sort of gender language is sort of where you get into the gray area. And so it's important that when we do our assessments that we really focus on what we're looking for. Do you have a uterus is a question that I could ask any patient instead of just saying, have you had a hysterectomy? Some people will think, oh, I had a hysterectomy, but they assume that means ovaries, and some people think it doesn't. I always love the term that, patients have given that's outdated. I've had a partial hysterectomy. And in their mind, they think that means, I've just had my uterus taken out and not my ovaries. That's a totally different procedure. And there is no total versus partial hysterectomy, right? You can't take half the uterus. So you have to do an organ inventory, just as you would for any other patient. Did you have a hysterectomy? Was your cervix removed? How was that done? Do you have your tubes and ovaries, or did you just have those removed? And so I think it's important to look at the organ inventory and what parts folks have.
Jamie,
yeah.
Just to jump in on that's super helpful information, because all I can continue to think about are those black and white team members around HCG testing, right? For years now.
That's exactly where I was going, because that's, to just say, is there any chance you could be pregnant? I don't know. That's a nicer way to say it than, I'm going to take your urine and take you for a pregnancy test. That can be really traumatizing to somebody who doesn't identify as a woman. If you've got a non-binary person or, a trans male, and now you're taking them for a pregnancy test, why? Especially if they've had surgery. But even as a cisgender woman, if I'd had a hysterectomy and somebody's doing a pregnancy test on me, why?
You're going to feel a certain way about that.
Yeah, it does. It makes you feel a certain way about things. And so, having the organ inventory first, but also making sure that you don't look at the flip side of that. Just because somebody's on hormone therapy doesn't mean we shouldn't do an HCG. But how do we do that HCG? Do we traumatize them and put them in the bathroom and make them pee in a cup? Or do we, look at it from a different perspective? Do we send a lab off and make sure that we, get a qualitative HCG or something like that? So really, there's some nuances to that. And even saying, if I have plenty of cisgendered folks that identify as, gay or queer, and if I have a patient who identifies as gay and she's like, no, I don't have sex with men, we need to be asking those questions of, are you, do you participate in sex that could result in pregnancy?
Right.
So, there's a lot of different ways that we can ask these sorts of things that, take a lot of the stigma away and don't re-traumatize folks. So yes and no, there's some considerations, but not what most folks think.
I'm going to use your words, Jamie. I use mine black and white. You use nuance.
It is all about nuance.
Understand that. Yeah. As I've educated myself over the years on on transgender and gender diverse care. There's nuance. So
Absolutely.
speaking of nuance, I want to take it back to the patient centric and their focus on the day of surgery. So again, imagine patient coming in for surgery. What do you all provide to that patient population who may have anxieties or concerns specific to their gender identity related to surgery?
Um, I don't know if there's anything specific that we wouldn't provide for any other patient. It's a very big day for these folks. And particularly depending on what stage they are in their surgical course, if any. It can be, top surgery, and that could be all that the patient wants. And their journey stops there. And that's a big day for them. Whereas somebody else might be having bottom surgery, and that's a big day for them. Really, it's about being supportive as we would for any other patient that comes through our doors. We're going to include their care partner, whoever that is, and whatever that looks like.
Now, let's help our PACU nurses. So if we transition our minds to post-operative care, curious to know, are there any considerations for pain management that may be specific to the transgender or gender diverse patient who's undergone gender affirming surgery?
Not really. Not specific to gender affirming care. But one thing that I've noticed that we see a lot of is, particularly with this population, a lot of history of anxiety and depression, and those sorts of diagnoses in turn. And I'm not saying that this is every gender patient, but this is something that comes up is, self-medicating with cannabis at times. And again, that could be any patient that comes in for any number of things. But it is fairly prevalent. So if you're thinking like, what do I have to think of? I think looking at a context of all patients, we need to look, particularly if somebody has an additional diagnosis of, anxiety or depression or just recreational use, that we need to look at with pain management, because definitely there are newer studies that are coming out that show cannabis use and interaction with pain management. It can be difficult to control, but I wouldn't say that it is any different than any other patient who participates in cannabis use. So
it's more of a holistic approach as it pertains to that. Okay.
Yeah. And really approaching just any other patient.
Exactly. No, I'm hearing that theme, and that's refreshing, given especially your expertise, Jamie. What about from a patient privacy perspective and considering their dignity when it comes to toileting and or dressing needs for the transgender and or gender diverse patient post-surgery?
So that can be tricky. Pre-post, any portion of that perioperative experience, even if they're admitted to the floor, it can be it can be difficult. You do want to make sure that they are treated with respect and dignity. They are going to have a heightened awareness related to their body than the average patient, right? That's what they're coming in for, is the ICD-10 code and diagnosis of gender dysphoria. So anytime that we are looking at anything, which in our case is going to be the surgical site where we're operating for the most part, that's going to be the big ticket item. So I think approaching it with respect, not asking questions about their body or genitalia when it is not appropriate. Number one is, the ultimate. If they're coming in for an appendectomy, I don't need to know about your bottom surgery. If we are looking at it from the post-operative, say somebody comes in pre-operatively and they are having a mastectomy, they're, maybe doing some chest binding or things like that. We want to make sure that we give them an opportunity to maybe undress privately or with their care partner. Obviously these patients are, when they're coming in for elective surgeries, are not coming in, fully, dependent on the nurse to be able to undress them and things, but also being respectful that if the person is not comfortable and that's going to re-traumatize them, making them take that chest binder off before they go into surgery, we may not. Now, is it ideal to go into the operating room that way? No, but it's going to be more harmful to the patient to cause that trauma to them before they're sedated. So we may have them remove everything but the chest binder and then go into the OR. And every patient is going to be different, right? The most important thing that you have to remember when doing this care is just ask. Ask what's okay, because if one person says it's a problem, another person may be okay with it. If you've met one trans person, you've met one trans person. So you really need to make sure that you tread lightly and with respect in regards to all of that. Did that answer your question?
It absolutely did.
Okay.
And what I'm hearing from you is be flexible.
Absolutely.
We're all caring for patients. All of them are unique. Be flexible. Keeping the chest binder on is not the end of the world. We can deal with it in the operating room.
Yep.
I appreciate it very much. Very much. What about from a support system perspective? If you think about, I personally can only imagine the potential emotional or mental health needs that may arise after surgery for these patients. What would you say to that, Jamie? What do we need to keep in mind?
I mean, that is a significant concern. And a lot of this leans on the surgeon doing their due diligence and ensuring that there are the things done right prior to surgery. So first of all, it's going to depend, obviously, if the patient is self-pay versus, some other type of insurance. A lot of insurances require the physician before they will approve these surgeries to go through that guideline. Those guidelines are based on WPATH standards. And I will say WPATH is more we are the starting base versus we are the ceiling of what should be done. And so it's really a jumping off point for standards. It doesn't mean that that's like it. We stop there because we do want to look at that psychosocial aspect of everything. So even when WPATH says, oh, we can do away with some of these things, a lot of times insurance companies aren't going to catch up with that. So a lot of those standards are going to be, that they require certain letters from providers and, prior to moving forward with surgery just to get it approved through their insurance. And that a lot of that legwork is done. I know that the offices will also make sure that, with these letters, they're usually from a mental health provider. So, they're making sure that they have routine care outside of that. Some of these practitioners even make sure that there is a mental health appointment within the first 2 months because studies show that they get these post-op blues sort of in that time period. So they want to make sure that they're covered. And that's not unusual. And again, these sorts of things would happen if you're having a cisgendered patient who's having something where you're looking at your gender, say a hysterectomy or a mastectomy for, cancer. You're going to have these same psychosocial issues, not just because you're a trans person. So they are really fabulous about making sure that these folks are doing this for the right reason. There's screening out there that the physicians will do that look at the difference between gender dysphoria and body dysmorphia and making sure that they don't show signs of one and not the other, because honestly, it doesn't matter if it's a cisgendered person or a trans person, you think we're fixing it. And then you've got these nuances that get into body dysmorphia, in the plastic surgery realm, like where it doesn't matter how much you fix it, the patient's got something else going on that we're not going to be able to care for. So a lot of this is dealt with outside of that. I will say our pre-admissions nurses and our navigator will make sure that a lot of this is in place, make sure that they have somebody to care for them post-operatively, that they're not just going back, back home and they don't have, a place to receive services. Our gender navigator is fabulous if they're from out of state, making sure that they have the right people set up and physicians that they can follow up with after they're done with their surgeon. So, Obviously, that's a little more because not everybody's going to necessarily be running a gender affirming program with out of state patients like we do. But, these are other things to consider.
They are. And there's a lot to consider. And again, in my mind, I'm going back to a common theme, which is there are similarities of care between all patients, maybe highlighted in a different way, or maybe you need to think a little bit more about it for this subset of patients, but the same as we all deal with in the healthcare. Well, Jamie, thank you again for joining us. We really appreciate your time, your expertise, and, because our goal is to reach as many nurses as possible. And by sharing these I believe easy tools, I think we're providing better care tomorrow for gender diverse patients. So thank you again for your time.
Thank you so much. Appreciate it.
Thanks everyone for tuning in. Really hope you got something out of this episode. If you did, tell us in the chat below. We'll see you next time on Periop Talk.
Enjoyed the episode? Please like, comment, and subscribe. For additional Periop content, look for us on Instagram at AORNPics and on Facebook and LinkedIn at AORN. You can also find us at aorn.org. Thanks for listening.